This is the third part of chapter 9, which is about friction and binding, which affect resistance to sliding. So when you slide canine against or on a wire, you expect to have friction during that movement and resistance to sliding. When we try to slide teeth on a wire, like if you want to retract canine in extraction cases, you need enough force to overcome, first to create or to induce remodeling in the periodontium around the teeth to allow them to move, and second, you needed to overcome resistance within the bracket between the wire and the bracket. So when we try to move the canine, we expect to have friction at the interface, which creates resistance to the direction of movement. Friction was found to be derived from the electromagnetic forces between the atoms, which what we call adhesion, molecular adhesion between the two surfaces. And it was found to be proportional to the force with which contacting surfaces are pressed together and affected by the surface or the nature of the surface at the interface. The nature of the surface, we're talking about the roughness of the surface and the chemical reactivity of the surface. We're going to talk, we'll see which has more effect, whether the roughness of the surface or the chemical activity of the wire, or what we call coefficient of friction. Friction was found to be independent of the apparent area of contact between the two surfaces. Why is that? Because it was found that surfaces, no matter how smooth they are, they have irregularities between them, roughnesses inside at the molecular level. And this shows that the real contact occurs at certain points, which we call asperities. And frictional resistance depends mainly on the force that is needed to produce the plastic deformation of these asperities, to shear them and to allow sliding. Apply to shear the asperities and try to slide the tooth or the bracket over the wire. The coefficient of friction, what we call coefficient of friction, معامل الاحتكاك, is proportional to the shear strength of the junctions and is inversely proportional to the yield strength of the material, whether it's nitrile, stainless steel, or TIM A. So when we have a material that has high yield strength, we expect to have a coefficient of friction lower, and vice versa. What happens that there is a phenomenon called stick-slip phenomenon. So as we build force to overcome or shear the junctions, there will be a jump of the wire forward when it moves forward. Then the surface will stick again until enough force builds again to break the other asperities, and vice versa, and so forth. So it's like stick-slip phenomena. The wire will stick and then it will jump and then stick and it will jump. Factors affect friction. The one we mentioned before in the previous slide, the force necessary to shear the asperities, the junctions between the two surfaces, and then the resistance caused by the interlocking of roughness between the two surfaces. So it depends on the size of the asperities and shape, like are they large or pointed? So we need force to overcome this resistance. And the third important factor is the plowing component of the total friction force. Example for this, like when you have two surfaces, hard and soft surfaces against each other, the hard surface will make pressure on the soft surface. Example, when you try to walk on sands, your feet will sink in, so you need some force to drag your feet along the surface to move on. Another example, when you have rubber tires flatten out at the area on contact with the road. So all these examples, and they occur because we have difference in hardness between the two materials. When harder surface touching softer surface, so we'll have some pressure. This is another or a third component of the total frictional force. So when we use stainless steel wire, like stainless steel wire on stainless steel brackets, the surface are almost similar and relatively smooth. You expect that friction is largely determined by the shearing component mainly. The concept that surface qualities play a role in friction, in determining friction, was experienced lately when both titanium wires and ceramic or plastic brackets were in use in orthodontics. So when we have stainless steel wire over stainless steel bracket, situation is almost acceptable because it depends only on the shearing component of the force. However, when we have other combinations like stainless steel wire on ceramic brackets or plastic brackets or night-tie wire over stainless steel, so here we expect that friction will be affected by other components. However, it was found that there is little or no correlation for orthodontic wires between the coefficient of friction and surface roughness. So interlocking and plowing are not that significant components of the total friction resistance when compared to the force needed to the shear force needed to shear the asperities. And although night-eye wire was found to have the highest surface roughness when compared to beta titanium and night-eye and stainless steel wires, turns out that the titanium content and its surface reactivity are the ones that determine the friction resistance, which has the major influence. In other words, it's not the surface roughness. And when we look at the wires, beta titanium has the highest titanium content, which is 80%. So it was found to have the highest coefficient friction when compared to the titanium, the beta titanium wire, which is 50% titanium content, and also when compared to stainless steel wire. So beta titanium is not the wire that you should use to do sliding. Why? Because the wire tends to cold weld itself to a steel bracket when you try to slide it. So sliding is almost impossible to do. So again, just to go back to the properties of the wires, we said that titanium wire, the beta titanium, is good for finishing at the final stages or the late stages of orthodontic treatment, and not for aligning and leveling or for space closure. That's why, because of this, the highest content of titanium, which is 80%. To improve the quality of beta titanium, the surface reactivity of beta titanium wires, ions like nitrogen, carbon, and other materials were implanted into those materials, and they were successful. Those techniques were successful in implant industry. However, in clinical orthodontics, such implantation wasn't that useful to improve NiTi and beta titanium performance, especially during initial alignment or sliding stages. Bracket surfaces are also important in friction, similar to the wires. So with the stainless steel brackets, we assume that the friction going to be, or their features are similar to stainless steel wires. Newly introduced brackets, titanium brackets, were found, which were introduced to be used for those patients who have allergy to nickel, where we cannot use stainless steel brackets, and also are found to be similar to titanium wires when it comes to friction. So they have very high friction and they are problematic. In addition, it was found that smoothing the slots of the bracket inside the slots is difficult, so which make them even worse than the wire regarding friction. We also have ceramic brackets in the market that are found to have also higher friction than stainless steel brackets. We have two types of brackets: polycrystalline ceramics, brackets were made from polycrystalline ceramics, and those that have only single or monocrystalline brackets. And in general, it was claimed that polycrystalline ceramics have higher friction because they have considerably rougher surfaces than steel brackets, and they are known to produce or penetrate the surfaces of even stainless steel wire. They make nicks in the stainless steel wire during sliding, creating considerable resistance. And this is even more problematic with titanium wires. And the other type, which is poly or monocrystalline or single crystal brackets, were claimed at the beginning that they have better qualities than polycrystalline ceramic brackets, but they found, although they have quite similar or smoother surfaces than the polycrystalline one, they still have similar friction to the polycrystalline, maybe less, but they create damage to the wire during sliding. Recently, new brackets with metal inset or metal slot, so the slot inside the bracket is made of metal. They were introduced, and which also have rounded corners to create or to reduce binding and notching during tooth movement, and they claim to have better qualities than the polycrystalline ceramic brackets without metal slots or even the single crystal brackets. Also in the market, we have composite plastic brackets that are recently introduced, and logically they have the advantage of being tooth colored and non-allergenic, and in theory at least they have smoother surfaces than ceramics, so we assume that they have better quality. However, their fabrication is still difficult and they're not properly used in or commonly used in orthodontics. As we mentioned earlier, the amount of force between the wire and bracket strongly influences the amount of resistance to sliding. And resistance to sliding include two types or three types. The first type is the classic friction that we covered so far, which mainly depends on the contact between the wire and the walls or bottom of the brackets. And another type which we call binding, which could be elastic and inelastic binding, that depends on the contact between the wire and the bracket at the corners of the brackets. So these are the two types of resistance to sliding. In this, the elastic binding, and then in inelastic binding, the elastic binding mainly occurs when the wire start, or the tooth, tends to tip. If you are sliding a tooth on a wire, because of the resistance at the root, and because we are moving the tooth at the level of the crown away from center of resistance, so expect the tooth to tip. So when it tips, the wire starts to touch the bracket at the borders, at the corners, and at this point we start to have another type of resistance to sliding, which we call binding, elastic binding. And it was found elastic binding is more important and more elastic binding is more important than classic friction. So classic friction is considered as nothing compared to the binding effect, or resistance to sliding due to binding. This is what I said. If a tooth pulled along an arch wire, the resistance to sliding will be only friction at the beginning until tooth tips enough to bring the corner of the brackets into contact with the wire. The tooth tips, of course, because the force is applied to bracket at its crown and center and away from center of resistance. As soon as the corner of the bracket engages the wire, which happens after a very small movement of a tooth, a moment is generated that opposes further tipping. This generates the elastic binding. So whenever we have angle between the wire and the bracket, then we expect to have more resistance of sliding in the form of binding, not as friction. In these two pictures, you can tell in laboratory, if we don't apply any force on the wire against the brackets, we expect to have no resistance to sliding whatsoever. But in reality, we apply force with ligature wirings, for example, or with any kind of elastomeric tie to activate the appliance, and this creates resistance to sliding in the form of either friction, as I said before, or binding. Friction due to the pressure, or it's started or activated when the wire touch the bottom and the side on the walls of the bracket, and when the tooth start to move, after some movement, we expect to have binding. In other words, when an angle is created between the wire and the bracket, you see here, then we start to have another form of sliding or resistance to sliding, which we call binding, especially which is called elastic binding, and this is even more than the classic friction, more important to consider when we move teeth than the classic friction. And this shows the difference between the wide and narrow brackets, which we mentioned previously or earlier in the second part of the chapter. So what we said, the narrower brackets will have more or larger angle between the wire and the bracket than wider brackets. So expect narrower brackets to have more binding effect, more resistance to sliding than wider brackets. The greater the angle at which the wire contacts the corners of the bracket, the greater the force between the wire and bracket. So as we noted previously, there is greater resistance to sliding with narrow than wide brackets. So as can be seen from figure 9.28, resistance to sliding include elastic binding almost immediately when tooth movement begins and goes up rapidly as the angle between the bracket and the wire increases. This explains the elastic binding. Kaseys laboratory conducted a series of experiments to see how or to look at binding versus friction as components of resistance to sliding. What they did, they used 21 by 25 M-nitrile wires and steel wires, which were tied into auto-2 slot stainless steel bracket with 200-gram ligature force. So they then evaluated friction, or evaluated the resistance to sliding as a function of the angle of contact between the wire and the bracket. So they evaluated the change in angle at 3 degrees contact angle, and then at 7 degrees. At 3-degree contact angles, most of the resistance to sliding was binding with a steel wire, and nearly half was binding with M-nitrile wire. At 7 degrees or greater angle, or more than 7 degrees, almost all the resistance was due to binding with both wires. So as we increase the angle, we expect to have more of binding effect than classic friction, either in nitrile or in stainless steel wire. And you can read here. I give you some time to read the experiment and see how the angle change affected the amount of resistance to sliding. So the conclusion for this, that for every early alignment of teeth, resistance to sliding is due to combination of friction and binding, but almost immediately, unless the tooth is allowed to tip or to keep the contact angle low, the friction component becomes so low that is considered as negligible component, and resistance to sliding is mainly due to elastic binding. And the author here is also referring to another type of binding, which is called inelastic binding, that occurs whenever we start to have notching of the edge of the wire against the bracket. So when the wire becomes notched, then you expect to have more resistance to sliding. And this will stop or prevent displacement of teeth. So with function, when you bite on your teeth, this notching will be released to allow the teeth to move. So function with occlusal forces will tend to move the teeth in different direction, and with this type of function we could expect to release the notch due to, of course, alveolar bone bending under heavy loads like mastication forces. So that's why this type of tooth movement was described as series of steps, not as smooth flow of movement. So because of what happens during tooth movement due to binding and due to notching, so we consider that the tooth movement happens almost entirely in a series of steps and not in a smooth flow. This slide shows scanning electron microscopy images of 16 round nitrile wire and I think 21 by 25 steel wire. You can see how after sliding movement there were significant damages or distortion or tear in the wire, and here indentations in this rectangular wire. So as the teeth, as the wires or the bracket slides over these wires, we expect, as we said, we expect tipping movement to occur. Then if the brackets catches on these damaged areas, then we expect, like the notches here, this is another type of notching that we expect to have we expect tooth movement to stop. And how it gets released? It gets released by masticatory function. So when we eat and try to bend or apply masticatory forces on the teeth, bone will bend and these notches will be released to allow tooth movement. So this shows you the importance of sometimes checking the wire and changing it every time, and then to avoid to avoid this kind of notching. So notching here can occur due to these damages that sometimes happen to the wires, and also when the wire bend against the bracket edge or the corner of the bracket. Here the author is talking about magnitude of resistance to sliding, how much force we need to resist or to move a tooth. As we said, we need force to resist to overcome resistance to sliding, and we need another component to initiate remodeling to move the tooth itself. So if we need 100 grams of force to move a tooth to initiate remodeling, we need a double or another 100 grams to overcome the effect of binding and friction. So the total force needed to slide the tooth therefore is twice as great as might have been expected. And here the author is showing or giving you an argument about self-ligating brackets, and he's saying because the resistance is due mainly to binding, is mostly to binding, so using self-ligating brackets, which reduce classic friction because it reduces the force against the walls of the brackets, will not give us faster space closure. This is against the idea that self-ligating brackets are considered or described as minimum friction brackets. Yes, minimum friction brackets because they reduce the force needed or to reduce the forces that press the wire against the walls of the brackets, but they don't reduce the resistance to sliding created by binding, which is due to the angle created between the wire and the bracket. And almost this force level is very difficult to predict, but in general we need force enough to overcome resistance to sliding, at the same time produce biological response. If you use a force that is larger beyond this force level, then maybe you expect to have anchorage loss, because this will start to bring the anchor teeth up onto the plateau of tooth movement, and these anchor teeth will start to move. That's why, to avoid this unnecessary movement, we recommend using headgear or bone screws to prevent any movement of the posterior teeth forward. This is when we close spaces, like for extraction, for example in extraction cases. That's why, to avoid loss of anchorage and to avoid resistance to sliding, there is another way to close space, which is by using retraction springs. Retraction springs or closing lobes will try to bring the anterior teeth backward on the wire by moving the whole segment back without any kind of friction. What they call frictionless mechanics. You can see we add loops, and then with elastics to take anchorage from the lower, we try to squeeze this loop and move the anterior teeth backward without sliding. So these are this is called frictionless mechanics or looped arch wire mechanics. Now in this part we're going to talk about anchorage types. What is anchorage? Anchorage, as you know, it's defined as resistance to unwanted tooth movement. So when we have extraction cases, when we extract teeth in crowded cases, we need to utilize the space totally to align teeth and put them into the arch sometimes. And this is what we call maximum anchorage. So we don't want the posterior teeth to move forward that much. We need to utilize most of the space to align anterior teeth. So in order to create maximum anchorage, we have to do additional procedures in our mechanics. So in this part we will talk about anchorage types, and this is one of the types of anchorage which we call reinforcement anchorage, in which we reinforce posterior teeth either by adding more units to the posterior teeth, like if you do extraction of premolar, first premolar, you can add second molar to the posterior segments, and sometimes we can do by reinforcing anchorage using headgear, extraoral forces. So here, what the author is saying, it has been determined that reinforcement is desirable. However, this typically involves including as many teeth as possible in the anchorage. For significant differential tooth movement, the ratio PDL area in the anchorage unit to PDL area in the tooth movement unit should be at least 2:1 without sliding and 4:1 with sliding. So what they mean by periodontal surface area, if you add the periodontal surface area, like in our example here is when you extract first premolar. So the posterior segment will include first, second premolar, first molar, and second molar. So the periodontal surface area of the posterior teeth should be at least two to one when we compare it to the periodontal surface of anterior teeth from canine to the other side canine when we do tooth movement without sliding, and 4:1 when we do sliding. Anything less produces something close to reciprocal movement. So if the periodontal surface area going to be the same between anterior and posterior teeth, then we expect to have reciprocal movement. Half of the space of the premolar will be closed by moving the anterior teeth back, and half will be expected to close by moving the posterior teeth forward. And this periodontal surface area is called root rating, and was introduced by Ricketts. But in reality, it's not really that something we can measure when we do orthodontics. But you understand the idea that we want to reinforce by adding more units posteriorly. This is one of the methods. In other words, we're adding more periodontal surface area posteriorly to ensure that the anterior teeth move back adequately to resist unwanted tooth movement of the posterior teeth. So we can also reinforce anchorage by adding or using teeth in the opposing dental arch. Example, what I showed you before when we used closing loops to move the anterior teeth and using elastics. So in case of extraction in class 2 cases, you extract in the upper two premolar and try to move the anterior teeth from canine to canine, and you want to ensure maximum anchorage, you will use elastic, canine elastic from the anterior segment to lower molar. But you have to be careful here because we expect the lower teeth also to move forward, and you don't want to do too much movement unless it's designed and agreed on in the treatment plan, because you don't want to do a lot of forward slippage and you end up with too much flaring of lower anterior teeth. This is the example here. We need to extract. This is the example of extraction in the lower, like in class 3 camouflage cases. So to ensure maximum anchorage, we use the upper full arch with fixed appliance and heavy wire to ensure that the molar doesn't extrude. So this will help to ensure retraction of the lower anterior teeth without losing anchorage. So as I said, the third method to reinforce anchorage is by using headgear. and unfortunately headgear, it depends on the patient's compliance, and it's not acceptable by many patients, but it's a very good idea that we resist unwanted tooth movement by using extraoral anchorage unit, which is either the head or the neck, depending on the type of the headgear you use. So the force will be dissipated against the bones of the cranial vault or against the neck. The only problem with this is that the force here is not constant and continuous force, similar to the elastic. That's why they are types of intermittent forces and not continuous force. However, it's very useful if you have cooperative patients to wear the appliance, then why not? We can give the patients headgear, and on top of it we give him elastics to close spaces. And the orthodontists used to use what we call J-Hawks headgear. That the headgear is attached to the canine themselves with certain hooks, so we ensure we move the anterior teeth directly backward. Another anchorage type is the subdivision of desired tooth movement, and this is a way of reducing anchorage loss, and this was introduced by Tweed when he introduced extraction mechanics. So he decided to divide the anterior teeth into canines first to move them alone, and then moving the anterior teeth backward. And of course, this type of anchorage has advantages and disadvantages, and we're going to talk about this later. This is what we are doing. We try to move the canine first, slide it, and then move the anterior teeth backward. By dividing teeth into canines first and then anterior teeth second, this will reduce the anchorage loss posteriorly. And as I said earlier, the problem with this mainly that we will during sliding canine, we might tip the canines back and we might rotate the canine inward. So we need additional visits to align canines and upright them before moving the anterior teeth backward. In addition, sometimes it's not accepted by the patient because the spaces that were posterior to the canine will be anterior to the canines, so maybe not acceptable by the patients to have these spaces. A third anchorage type is tipping and uprighting. So what we do here, and this was introduced by Big in the Big appliance and Big technique, what they do, they try to move or divide the anterior teeth movement into tipping and then root movement. So this is so what we do, we are pitting tipping movement of the anterior teeth against bodily movement of the posterior teeth. So the force threshold will be enough to tip the anterior teeth back, but not enough to move the posterior teeth forward. And then after tipping the anterior teeth backward, you can upright the roots by using auxiliary uprighting springs as a second step. So if we have a case of extraction, first premolar extraction, and we want to close spaces, maybe sometimes it's desirable to close extraction spaces like in the ratio of 60-40. 60% to retract anterior teeth and 40% of the space will be utilized for by forward movement of posterior teeth. If we need to do this scenario, which is moderate anchorage, this outcome could be expected or can be done or can be achieved from three possibilities. Either we do one-step space closure with no sliding, with just T loops مثلا, with loops, closing loops to move the anterior teeth back. So using this in-mass retraction with closing lobes will achieve what we are planning for, 60% retraction of anterior and 40% of posterior teeth. Or we can do two-step closure sliding. We slide the canine first and then retract incisors by loop again. This also can achieve the same plan or the same objectives. Or the third option will be to do two-step closure by tipping anterior segment with some friction, then uprighting the tipped teeth by the big technique. So here again they're explaining to you the three methods that we are suggesting to achieve this objective of closing anterior teeth, closing extraction spaces, 60% moving anterior teeth backward and 40% moving the posterior teeth forward. And also another important factor that we should consider is the binding and friction and how it affects our movement. So sliding, of course, when you do sliding, you expect to have a lot of binding and friction. If you apply heavy force with these types of problems, binding and friction, you expect to have more loss of anchorage. So you have to be careful when you apply that, or when you decide the level of force you want to use. And you expect the space closure to be slower than if you try to do the same thing with loop arch wire instead of sliding. We expect with sliding to have faster, maybe faster movement than with sliding movement. A last type of anchorage is the skeletal anchorage. Skeletal anchorage, as you know, is derived from bone screws that are recently were recently introduced, like maybe 40 years ago or 30 years ago, and they are really very useful to eliminate unwanted tooth movement, to prevent forward movement of the posterior teeth when you do extraction, and also many screws can be used to achieve maximum anchorage during intrusion and extrusion forces, intrusion type of tooth movement, not only space closure. So when we say anchorage, it doesn't mean only resistant to unwanted tooth movement during extraction cases. No. The unwanted tooth movement is also expected during intrusion. If you want to intrude incisors, we depend on posterior teeth to achieve absolute intrusion. And unfortunately, as we intrude, we expect posterior teeth to extrude. So using mini screws also will be very beneficial to resist these types of unwanted tooth movement. And please note that many screws are different than implants. Implants depend in their retention on osseointegration. However, here the mini screws can be loaded immediately because they depend on mechanical retention. And also, in addition to these mini screws, bone screws, we have two types of bone screws: either mini screws that we are familiar with, and also we have plates, many plates that are attached with screws to basal bone of the maxilla or the mandible. Like in the maxilla, you can attach them to the zygomatic buttress bone or malar bone opposite to first molar, and in the molar, in the mandible, we can attach it also to the basal bone of the mandible. These devices are collectively called temporary anchorage devices, which include many screws as well as many plates. With properly designed skeletal anchorage, there is no concern about moving teeth that were not intended to be moved, like the posterior teeth in case of extraction example. But the amount of force to teeth that are to be moved still need to be determined with resistance to sliding in mind, and the desired treatment outcome must be determined with some precision before bone anchors are placed so they can be positioned to provide the proper force direction. For example, when you try to move anterior teeth back, if you want to use direct anchorage, you place many screws, for example, between 6 and 5. They have to be placed in certain place relative to center of resistance. And also, other biological considerations should be put in mind, like where to place it. Do you place the mini screws in the attached gingiva or the alveolar mucosa? The accepted protocol is to place them in the attached mucosa, maximum up to the mucogingival line. Here show you several examples of bone anchors that were used. For example, in A, show you how to place screws to hold a bone anchor in mandible, like to attach or anchor many plates in place here. B, this is showing the anchors, the many plates in place. And in C, this is a surgical placement of palatal anchor, which is Stroman ortho system. As you can see in D here, after placement position. And this is a way of doing indirect anchorage, where you can apply palatal plane to hold posterior teeth or to hold teeth and then allow movement of the other teeth. This is stabilizing lingual arch or palatal arch. And this sometimes we do punch in the mucosa and then insert our mini screws. And this is another example in G. You can see Thomas screws, dentarum brackets that are used to hold molars and allow movement of second molar forward, to hold first molar with the wire here attached to the tubes of the first molar, and to allow forward movement or protract second molar. So you have several examples, but you should keep in mind that there are certain protocols that we have to follow when we use mini screws. So which one we use? Individual bone screws, which are the mini screws, or mini plates? There are in general certain rules we have to keep in mind. If we have inadequate bone density or bone in the area, it's preferable that you use mini plates. If you need more force, maybe you can use mini plates. If you need to move many teeth, maybe you should use mini plates. In children, like age 14 or 15, and if you want to use any kind of anchor, like in class 3 treatment, maybe you can use mini plates instead of bone screws because you don't have enough or good quality bone. So the relative advantage and disadvantage of screws alone versus mini plates have been the subject of some controversy, but it seems clear that more anchorage that would be needed, the greater the indication for many plates and their multiple screws. So if you have missing teeth and you want to close a simple space, or you have impacted teeth and other similar problems that require movement of only few teeth, maybe alveolar bone screws will do the job. For example, also for intrusion of even multiple teeth, like the intrusion of posterior teeth, you need a very light force to do intrusion, then maybe mini screws will be adequate to do this type of movement. However, for more complex tooth movement, like moving the entire maxillary arch distally for class 2 camouflage, or when the desired force direction cannot be obtained with alveolar screws, many plates are sometimes required. Those many screws and many plates can be used as either direct or indirect, can provide direct anchorage or indirect anchorage. So when we say direct anchorage, it is when the teeth or tooth to be moved are attached directly to the bone anchor. Indirect anchorage, however, is when another tooth or teeth are attached to the bone anchor to hold them in position while the teeth serve as anchorage. Like for example, when you use palatal screws with transpalatal bar attached to first molar, you are using them to stabilize the anchorage teeth. With indirect anchorage, there is nothing different from what has been discussed previously. With direct anchorage, the location of the bone anchor must be carefully considered. Why? Because the line of force from it almost always is above or below the line of force from anchorage teeth. So either you place it above or below the anchorage teeth. So you have to be careful here. Why? Because you want to make sure that the line of action of the force goes through center of resistance to allow bodily movement. Many plates are better for direct anchorage. Why? Because they are really tightly anchored, and even though they are likely to be even farther from the teeth than isolated bone screws, because attachment to many plates usually allow placing a wire through the attachment so that the line of force can be varied. So still, with many plates, although they are away from the anchor teeth or from the teeth, high up or low, we can add wires so we can adjust the line of action and make it through center of resistance, for example, or whatever intended movement is desired. Another important factor that determines whether we use many screws or many plates is the bone quality where we want to insert the mini screw. If we have thick, adequate bone, maybe you can use mini screws. If you don't have, like for example, the area above the maxillary posterior teeth, maybe mini plates are preferred. The bone of the palate is also more dense than the alveolar bone, which makes it a favorite site for screws rather than plates. So palatally, where we can use mini screws to provide indirect anchorage, is a good place to place mini screws. Age is also an important factor. We cannot use mini screws until like early adolescence, because the bone quality, the bone density for most of these patients is not attained until that age, early adolescence. So maybe bone anchors cannot be used for most of the mixed dentition treatment. By this we conclude the anchorage, different types of anchorage, and finally we talked in details about skeletal anchorage. I want to add some other important information here that we should also determine when we plan mini screws use. We have to determine where to place our mini screws, the direction of the mini screws, especially alveolar one, and the safe areas that where you can place mini screws versus unsafe area. The safe area that have adequate bone, you should go and read about these areas, and the length of the mini screws when you use them in the maxilla versus the mandible, and also the different types of mini screws and the different uses of the mini screws, and finally how you can insert mini screws, the procedure to insert mini screws. All these have to be considered before you use mini screws. And also the periodontal consideration for using mini screws is important for you to know. For example, as I said, we have to place mini screws in the attached gingiva nut and soft tissue mucosa to avoid recurrence of infection and inflammation in the soft tissue mucosa. And also another important point to consider when we plan our anchorage, the location of mini screw relative to the center of resistance, which I emphasized several times, and I want to emphasize it again. It has to be considered when you plan mini screws. This concludes this chapter or this part.